Invitation. I'm very happy to be in beautiful Antalya again. I will speak to you about hypersomnias and the effect of vigilance promoting compounds. I will just go through some definitions that might be useful. I'll speak very briefly about etiology and the regulation of arousal states in order to focus on my main topic, which is the wake-promoting agents and their indications. So when we say somebody has hypersomnia, what we really mean is that he has the propensity to fall asleep in situations when he is expected to be awake and alert. Clinically, hypersomnia might present with prolonged sleep episodes, excessive daytime sleepiness, or EDS for short, and frequent napping. As you know, it's very highly prevalent condition and symptom and very frequently underdiagnosed. Actually, when we say that somebody has excessive daytime sleepiness, we might mean a number of things, and this depends on the clinical condition that we are dealing with. For example, in narcolepsy, patients experience excessive daytime sleepiness as short and recurrent periods of sleep during the daytime, so-called sleep attacks, regardless of how much and how good sleep they had the night before. In obstructive sleep apnea, when we speak of EDS, we speak of a higher propensity to fall asleep during the daytime, happening due to sleep fragmentation and or hypoxemia, both related to the intermittent apneas that the person experiences. In depression, where, as you heard before by Dr. Soldatos, 80% at least of patients have insomnia, patients very often complain of hypersomnia, but this has a totally different quality from what we described before. Patients do not necessarily have a higher propensity to go to sleep during the daytime, but they report subjective sleepiness, which is qualitatively different from EDS encountered in narcolepsy and obstructive sleep apnea. As you can see, because of the great frequency that hypersomnia is seen in various mood disorders, there are three classification systems that offer diagnostic criteria for hypersomnia associated with mood disorders. It's the DSM-4, the International Classification of Sleep Disorders, and the ICD-10. All three of them require as chief complaint excessive sleepiness, and they all three differentiate hypersomnia due to a mental disorder from hypersomnia from idiopathic or primary or organic hypersomnia. However, none of these systems quantifies the duration of the sleep episodes during the night or during the day, and everything is more or less subjective. Both the prolonged nighttime sleep and the excessive daytime sleepiness, there is no quantification of these elements. There are also differences among the three systems. Both the DSM-4 and the ICD-10 require at least 1 month duration of the symptom and distress or impairment in social or occupational functioning. And the only system that emphasizes the use of polysomnography for the diagnosis of hypersomnia is the International Classification of Sleep Disorders. And this is very important for psychiatrists because, as you can see here in this slide, it is very important to differentiate time in bed from total sleep time. And that's why the International Classification of Sleep Disorders, is really a very important classification system for the hypersomnia you see in mood disorders. In addition, studies have demonstrated that EDS is very common in clinical practice. An American study demonstrated that 43% of adults reported that they were so sleepy during the day that this interfered with their daily activities. And 1 out of 5 of these individuals experienced this level of sleepiness at least a few days per week or more. And of course, this has a price. It reduces efficiency at work, also leads to difficulties with concentration, memory, and mood. Regarding etiology, when we ask what causes hypersomnia, we have the so-called hypersomnias of central origin that we'll speak about very briefly in a minute. We have hypersomnia due to chronic sleep loss and or poor sleep quality, and this is the situation both in obstructive sleep apnea as well as in depression. We have hypersomnia due to various medical problems or medications, and also we have behaviorally induced hypersomnia caused by insufficient time to sleep. Regarding hypersomnias of central origin, we first want to remind you of narcolepsy, which has as main characteristics excessive daytime sleepiness with or without cataplexy, also sleep paralysis and hypnagogic hallucinations. This is a chronic neurologic disorder of sleep state dissociation, where you have segments of rapid eye movement sleep intruding into wakefulness. The second condition of central origin that we have hypersomnia is the so-called idiopathic hypersomnia, which is primary, without any evidence of structural or psychiatric disturbance, where you have EDS together with episodes of prolonged nocturnal sleep. And we also have two types of recurrent hypersomnia. One of them is the Klein-Levin syndrome with the behavioral disturbances that occur on top of the recurrent hypersomnic episodes, as well as menstrual-related hypersomnia. Now, in depression again, other interesting data come from a study that was published in 2005, where in a huge random sample of 16,500 individuals, almost 9% displayed excessive daytime sleepiness. What was very interesting in this study was something that came up that was contrary to what was expected. In other words, that EDS was more strongly associated with depression than with obesity, metabolic factors, or sleep-related breathing disorders. In children and adolescents, we also have a lot of hypersomnias. We have hypersomnia due to insufficient sleep from poor sleep hygiene that you just heard about, as well as behavioral insomnia of childhood. We have, of course, hypersomnia related to respiratory problems. We have narcolepsy, even though it very rarely gets diagnosed at this age. The narcoleptics who are diagnosed in adulthood, most of them say that their symptoms started in adolescence and some of them in childhood. We also have a lot of encephalopathies like mental retardation, cerebral palsy, where we have hypersomnia. We have circadian rhythm sleep disorders with the main representative, the delayed sleep phase syndrome that is very characteristic of adolescents. We have a lot of neuropsychiatric disorders, meaning ADHD, autism, and depression, and of course we have medical illnesses and medications that may cause hypersomnia. Now, the regulation of arousal states is very interesting, and it will lead us to our discussion on the wake-promoting agents. Sleep is regulated through very complex interactions between many brain regions and many neurochemicals. There are neurotransmitters and neuromodulators that underlie these processes, and these are noradrenergic, serotonergic, cholinergic, adenosinergic, histaminergic systems, and more recently we found out a lot about the hypocretin, orexin, and dopamine systems. And this whole study, which is fascinating in many ways, started with the findings of Economou in Germany, who, when he studied the pathology of the brains of patients who died of encephalitis lethargica, found lesions at the base of the midbrain. And this led him to hypothesize that this was the site of origin of the ascending arousal pathways. Now we know that wakefulness is a cortical function that depends on the coordinated efforts of the thalamus, the hypothalamus, the basal forebrain, and all of these areas integrate and relay information from the brainstem to the cortex. And we also know that the norepinephrine and serotonin are the main arousal-enhancing transmitters. However, glutamate, acetylcholine, histamine, and hypocretin, orexins, and adenosine are very important in signal transduction from these brain areas that I mentioned before, and initiate, promote, and enhance wakefulness. But most of the drugs we'll be speaking about actually have effect on norepinephrine. Let's not forget what's happening in narcolepsy. In narcolepsy, we have the lateral hypothalamic area, the neurons of the lateral hypothalamic area that produce the orexin that seem to fail in their work, and in doing that, what is lost is this very important switch that keeps us awake, because when these neurons fail, they stop stimulating the arousal system, and the person has a tendency to go to sleep without any intermediate stages. So, what wake-promoting agents do we have available to us? They are on the left of the slide, and we'll speak about them mainly, but we'll also make reference to the substances on the right side of the slide. Caffeine is the most popular psychoactive substance. Most of the people use it. What it does is that it's a non-selective antagonist of the adenosine receptors, so it's one of the rare stimulant drugs that does not go through the noradrenergic system, and its psychostimulant action has to do with its ability to indirectly stimulate the dopaminergic systems in the brain. From animal studies and from humans, we know that it increases wakefulness by delaying sleep latency and decreasing total sleep time. When compared with methylphenidate, caffeine is actually stronger, but as you know, there is tolerance that develops over time. The so-called psychomotor stimulant drugs are the amphetamines and methylphenidate. There are several compounds in these categories, each one with its own profile. They are all very successful at promoting wakefulness, and they have adverse effects on the cardiovascular system, and the amphetamines also have addictive properties. Both in humans, both dextroamphetamine and methylphenidate have been shown to have the effects I said before, to increase sleep latency and improve self-reported sleepiness. There is some rebound hypersomnolence and tolerance to both of them. The amphetamines facilitate norepinephrine release, and methylphenidate inhibits the reabsorption of dopamine and norepinephrine from the presynaptic neuron. And now we go to another category of drugs that are very popular these days, as I will show you, the so-called atypical stimulants, with the prime representative being modafinil, a substance that is very different from amphetamines in structure, neurochemical profile, and behavioral effects. It has robust effects on many transmitters and modulators, and the effects on dopamine and norepinephrine appear to be primary, while the effects on the rest of the substances appear to be secondary to catecholamine effects. It also has a very interesting feature that it's selective for cortical over subcortical sites of action, and when we say cortical, we mean mainly frontal cortex. It has approval for treatment of narcolepsy, shift work sleep disorders, and obstructive sleep apnea based on several randomized placebo-controlled trials. It has an excellent pharmacokinetic profile, and as a result, it's well tolerated. It has a low rate of adverse events on the cardiovascular system and low liability to abuse. It also has a very nice positive effect on cognitive functions, and this has been demonstrated in experimental animals, healthy adults, and in many psychiatric disorders. In healthy humans, either with sleep deprivation or without it, it has been shown to improve working memory, recognition memory, attention, and other tasks that depend on cognitive control. However, this effect appears to be related to the IQ of the person. In other words, high IQ might limit the detection of modafinil's positive cognitive effects. As a result of this positive cognitive effect, modafinil has been tried in many neuropsychiatric populations, and I will show you some data on ADHD, schizophrenia, etc. Adrafinil is the prodrug of modafinil, and it has been studied in France, where it has been shown to be efficacious as vigilance promoting and mood enhancing agent in the elderly. While armodafinil, again in the same group, it is the R enantiomer of modafinil, has a much longer half-life than modafinil, and it has been demonstrated to be efficacious as a vigilant promoting agent in patients with obstructive sleep apnea who, despite using CPAP, they have residual hypersomnia. In summary, as I said, both the amphetamines and the modafinil seem to work through norepinephrine, but also other systems. Now, where does this substance, sodium oxybate, fall in? You might know this from its illicit use to put young women to sleep in bars and clubs so that their companions could have sex with them without their assent. It's a central nervous system depression that has very complex pharmacodynamics, but the most important mechanism that it has is that it acts on GABA B as a GABA B receptor agonist. When given at bedtime, it improves sleep continuity and decreases nocturnal awakenings in healthy people, but when you give it to narcoleptics, having the same effect, at the end it consolidates REM sleep periods, and these effects coincide with an improvement in daytime symptoms, including cataplexy. Levothyroxine has been published to be effective in idiopathic hypersomnia associated with subclinical hypothyroidism by a Japanese group, and then the same group studied levothyroxine in idiopathic hypersomnia without subclinical hypothyroidism, and we wait to hear more about this. So, what are the indications of these drugs? First of all, narcolepsy. The treatment of narcolepsy has changed dramatically over the last few years. We came a long way from using caffeine to stimulants to now having a drug that is safe and efficacious like modafinil, and this is the most prescribed medication for this condition. But if you look at this list here, we have several drugs to treat excessive daytime sleepiness in narcolepsy. Still, we have the amphetamines, the methylphenidate, we have methamphetamine, and selegiline, which converts to L-amphetamine and methamphetamine. So we have a whole host of agents. For cataplexy, again, we came a long way from having behavioral treatments to antidepressants to sodium oxybate, which seems to be a very nice treatment for this. A word of caution. Many narcoleptics, I mean about 20–25% of them, also have obstructive sleep apnea. And in this situation, sodium oxybate might not be a good idea because it might make the obstructive sleep apnea worse. And how about obstructive sleep apnea? It would seem such a great idea to treat it with a medication, but unfortunately at this point there is no medication that can do the work that CPAP does, and I propose that you read this reference that I have at the end. It's a very nice paper that talks about all the medications. Yet modafinil seems to be very effective for those patients who use CPAP and they have residual hypersomnia. Both modafinil and armodafinil, that the R&D of this medication, we have studies that demonstrate their efficacy. Modafinil also has approval for shift work sleep disorder. It has been shown to increase sleep latency during nighttime shifts, and this is very important because these people can work better, but they're also protected from the accidents that they have during post-work commute. In idiopathic hypersomnia, the evidence is not that strong, and because of some rare side effects, the European Medicines Agency concluded that they would not approve it. And during this year, 2011, a French group published their work on modafinil in idiopathic hypersomnia and demonstrated that it has an excellent benefit-risk ratio for idiopathic hypersomnia as well. For Klein-Levin syndrome, there are not many medications that you can use. It looks that modafinil might be a useful drug because it reduces duration of symptomatic episode. Modafinil is also used in Parkinson's disease, where it helps the daytime sleepiness that these patients have. And there are many other neurologic conditions and medical conditions where it appears to be generally favorable. It's a nice review, this paper that I have down there. It's not useful for myotonic muscular dystrophy, and there are mixed results about its effect on schizophrenia. And there is also some concern that it can exacerbate psychosis. Finally, in depression, it has a favorable effect. There is a whole discussion why. Could it be that it acts on the circadian rhythm disturbance? Could it be that it acts on the element that has to do with the obstructive sleep apnea that is associated in 20% of depressed patients with the depression? In any case, it seems to be efficacious and also safe in depression, and this has led to a recommendation to use it as one of the strategies other than handling the antidepressants in order to promote wakefulness in depressed patients. A word of caution that it might, also it was encouraging, I'm sorry, not a word of caution, it was encouraging that they found out that it does not cause a switch to mania or hypomania, and also it has been used in cocaine-dependent adults with good results, and in adult ADHD, also in children and adolescents. However, I am personally not very impressed by this because I started once an open-label study, which I never published because I lost all my patients during the process. None of my children and adolescents who had responded to methylphenidate liked to be switched to modafinil. So I do not know. A word of caution on neuropsychiatric patients that it may make the anxiety worse, and that's why, and this has been demonstrated both in experimental animals and in humans, and so be careful when you use modafinil in these neuropsychiatric patients. So I went through all the data that I could find in order to present this topic to you, and at the end what I can tell you is that we need more medications with more specific therapeutic approaches for the various causes of hypersomnia that we have. Thank you.